the membrane pumps start to work. So you start to get intra and extracellular exchange early, but the cell needs energy. So the cell says, "Oi, mitochondria, energy please!" And the mitochondria start producing ATP, the same way as they do directly with red light. So it's indirect photochemical, direct photophysical reaction. And it doesn't really matter because the end result is the same, a photoactivated cell. And what happens with photoactivated cells? Well, if they're damaged or compromised, they will repair. They will either repair themselves or they will be repaired by their colleagues. If the cell has a job to do, for example, fibroblasts producing collagen, elastin, and proteoglycans, they will do that job better. And if there are not enough cells to do the job, they will proliferate to do the job. And in fact, studies have shown that compromised cells actually respond much, much better to light therapy than healthy cells, although healthy cells do, of course, respond. But it's interesting that a cell that's compromised will actually produce 250% more activity than a normal cell will produce when photoactivated. So we get all these calcium ions and protons, that's the Ca double plus and the H plus, and they come out from the cell into the cytoplasm, and they find a cell that is not photoactivated, and they knock on its door and they activate it. And this is called the bystander cell theory. And it means basically you don't need to irradiate all the tissue, that nearby cells are going to benefit from the photoactivation of their neighbors. So this is important when we think of the systemic effect of phototherapy. Any questions about cells and their bits and pieces? No, right, on we go. So what is the main process? Well, as for us, if we're not considering pain, which is a different process, the major process that is kick-started is the wound healing process. Now, it doesn't matter if there's not a wound. You'll see as I go through the presentation that there doesn't have to be a wound for the wound healing process to be activated. And during the wound healing process, we have different cells doing different things at different stages and in different numbers. So if we look at these cells and we think, how can we activate that cell? Then you see where phototherapy comes in to the wound healing process. The first stage of the wound healing process is inflammation. Now, most people will say, inflammation, no inflammation. Actually, inflammation is a necessity. If you don't have inflammation, you will not get proliferation. Anybody who is familiar with overdosage of anti-inflammatory steroids will know that steroid-treated wounds take ages to heal because the steroids are suppressing the inflammation and suppressing the work of these extremely important cells: the mast cell, the macrophage, and the neutrophil. Mast cells are like your body's chemist, pharmacist. They contain a bunch of really interesting cytokines, chemokines, and growth factors. They also help protect against vasospasm, and they have a very powerful antioxidant which also appears at the very end of degranulation. So we get more inflammatory stage cells recruited and we get growth factors released. With macrophages, the macrophage is like the dustman, the garbage collector. It goes around gobbling up all bits of old cell, bits of destroyed collagen, and it keeps the matrix nice and clean. But as it does this, it releases a wonderful factor called fibroblast growth factor. And when you heard from Ron's talk this morning, FGF activates stem cells. It doesn't just activate fibroblasts. You probably remember the game Pac-Man, when Pac-Man would rush around gobbling up cherries and all that sort of stuff. Well, FGF is like a cherry to a fibroblast. the fibroblast goes once it gets its dose of fibroblast growth factor. So this stage is essential to produce a nice environment for the proliferation stage which follows. And finally, the leukocyte or neutrophil is the first line of defense against invading microorganisms. And even when it's not fighting microorganisms, they release transforming growth factor, in particular TG alpha and TG beta. So then we move into proliferation. And the inflammatory stage is from day 0 to about day 3 or day 4. At about day 3, proliferation starts, so the phases are not clear-cut. There is interchange between them. And the first thing that happens is that all these cells drop back to their pre-wound levels because they're no longer required. Therefore, they don't stay in high levels, and instead we find the fibroblast and the endotheliocyte. And of all the cells, the fibroblast is the multitasking cell. It maintains matrix homeostasis. It can ask for degradation of old collagen and replacement with new collagen. It can produce elastin to make elastic fibers, and it keeps the glycosaminoglycans or ground substance in its good state. So it's an extremely important cell. And the endotheliocyte is like a baby blood vessel cell. They clump together to form the endothelium or wall of new blood vessels to repair a wound or to bring oxygen via blood into areas which require it. And then we move into the longest phase of wound healing, which is called remodeling. And remodeling is extremely important because during this proliferation phase, lots of collagen is made, which is a bit higgledy-piggledy. And then we have this very important cell, which is called the myofibroblast. So myo means muscle, and this is a fibroblast with muscles. And these little tufts you see at the end of the myofibroblast have little hooks, and it hooks into the collagen fibers, and then the muscles contract, and that pulls the collagen into really nice alignment. So instead of having collagen all over the place, you have nice stratified collagen, giving the skin better resilience, and with the glycosaminoglycans, plumper. And this is how we get rid of wrinkles. Some of the myofibroblast, right, with muscles, but unfortunately the poor old myofibroblast has limited use, and once it's finished, it goes into apoptosis and it dies all. But then some other fibroblasts, because there are still too many fibroblasts, some of them de-differentiate into fibrocytes. And a fibrocyte is like a unipotent stem cell. And it sits there in the dermis until it's needed, and then it re-differentiates into nice new collagen fiber. And when you get tissue that's treated with phototherapy, you find more of these fibrocytes, so we're actually laying down some protection for future restoration of collagen should it be needed. Right, skin cells and wavelength. Now we come to the light interaction with these different skin cells. When we look at the wavelengths that are available with the Healite, we find 450 nanometers blue, and it will penetrate about 1 millimeter, 1000 microns, into the tissue. But it has very limited targets. Its only target is porphyrins within Propionibacterium acnes, protoporphyrin 9 and coproporphyrin 3. And I will talk about this in more detail when I talk about acne. And this is endogenous photodynamic therapy. 590 nanometers is paired with 830 nanometers in the infrared head. And its targets are purely epidermal, keratinocytes and epidermal Merkel cells. Because when we look at the mirror, we don't see a dermis, we don't see beautiful blood vessels and lovely collagen and wonderful elastin, we see the epidermis. And if we haven't looked after the patient's epidermis, they get SOE, same old epidermis, and they don't like it. You say, yeah, but look how wonderful, look at your specimens, look at all that collagen. They say, never mind the collagen, what about me skin? Right? And that's why we must never neglect the epidermis. Then 633 is much better penetrating. It can go as deep as 12 millimeters. And its targets are fibroblasts, endotheliocytes, mast cells, blood vessel walls, and porphyrins, because one of its main applications is for exogenous photodynamic therapy, or PDT, with a substance, most popular one is called aminolevulinic acid, 5-ALA. And then we come to 830, and 830 penetrates centimeters into tissue. Now, many people who should know better will tell you that light stops within the first few microns of tissue. Deluded people. Can you see any red light coming through my finger? How thick is that? About 12 millimeters. And where you see light coming through, there are still photons. So light does not stop in the first few microns of tissue. It penetrates depending on the wavelength. And the red wavelength is a good penetrator. Alrighty. So let's look at some of these cells specifically. These data are taken from these two papers, meta-analysis by Woodruff on wound healing, wound repair, and one by Contoes, Vakis Contoes, on LED phototherapy medicine for the new millennium. So we look at a number of wavelengths. We look at yellow, and we look at red, and then near infrared down here. And then we look at the wound healing phase cell types and their action level. We get inflammation, proliferation, remodeling, and then all stages of the skin. In inflammation, as you remember, the main cells are the mast cell, the macrophage, and the neutrophil. And if we look at the literature to see what wavelength activates these cells best, it's our friend 830, both in vivo and in vitro. And here's a little experiment that my colleagues and I did a couple of years ago. We took 8 healthy sports university students, skin type 3, they were Japanese. The study protocol was the right arm was experimental, the left arm was the unirradiated control. First of all, 3 millimeter punch biopsies were taken from both arms and processed for transmission electron microscopy. Then there was one single irradiation of the right arm with the LED system, giving 60 joules per square centimeter, which is the recommended dose of the Healite. 48 hours later, punch biopsies were taken from both arms, the irradiated and the control. And we assessed with gross observation to see if there was any physical change in the color of the skin. For example, did they get erythema? Did it turn red? Then we looked at transmission electron microscopy at a cellular level, and then we also did cell counts per field, mast cells, macrophages, and neutrophils. This is a transmission electron photomicrograph of normal skin with a magnification of 9,000 times. And this is normal. It's a nice, tight matrix with very few spaces. And then here you see a fibroblast, and it's surrounded by collagen fibers here, and these are bundles which are in cross-section, so collagen bundles. Here we have a blood vessel, nice little arteriole. And down here in the bottom left, we have one single solitary mast cell. And you can see its characteristics. All these little granules, all these little black dots contain these exciting substances. And when these are degranulated, in the case of a wound, they help the wound get over the inflammatory stage as quickly as possible. All right, now we look 48 hours after in an irradiated arm, and we see a completely different picture. This is not damaged, this is normal tissue. There is no damage. However, what you see are many interstitial spaces, lots of spaces between the components in the skin. You see edema, swelling around these blood vessels. Right? Here is perivascular edema. And you see some macrophages, and you see some leukocytes, which is very unusual because this is healthy tissue. And leukocytes are only there to fight. but they've been brought in by the one single irradiation. And if we look at these mast cells, these degranulating mast cells, they're nearly all degranulated. Mast cells, macrophages, and neutrophils. We compare the counts pre, post, and control. Not any difference between pre and control, statistically significant difference in post. So all of these cells were pulled into the area by one single LED irradiation with 830 nanometers. What does this mean? Well, it means that the tissue thinks that it's been wounded, but it hasn't been wounded. However, it thinks it has, so there is an inflammatory response, and what follows inflammation? Proliferation. So we've started the wound healing process without causing a wound. And the wound healing process is essential for skin rejuvenation, to produce lots of collagen, lots of elastin, and nice ground substance. And this also applies to macrophages and neutrophils. A couple of papers there in which macrophage responsiveness to light therapy, and this was 830 nanometers diode laser, but it was defocused to approximately 45 joules per square centimeter. And in the case of both macrophages and neutrophils, they sensed their target faster. They moved to the target faster, chemotaxis. They engulfed their target faster and got rid of it faster. So efficiency was the name of the game. And both cells gave off measurable amounts of growth factors. Fibroblast growth factor for the macrophage and transforming growth factor, alpha and beta, for the neutrophil. So then we move on to proliferation. And we find that a number of wavelengths actually are very kind to fibroblasts. 830, 633, and our friend 590. And this was done in vitro. It was done in a little microscopic study, not in vivo, because you remember yellow light cannot penetrate into the dermis really well, so it doesn't affect fibroblasts in vivo. But it's interesting that it affects it in vitro. However, 830, 633, 633 is very good for fibroblasts. Here's a little experiment. 7 volunteers. They were treated on the left calf. The right calf was the control. Punch biopsies, and then 4 irradiation sessions of the left calf with 633 at 126 joules per square centimeter, 48 hours between sessions. Punch biopsies from both legs at 48 hours post-irradiation, and assessment was gross observation and transmission electron microscopy. This is a nice healthy looking fibroblast. It's actually half of a fibroblast because the other half goes off the screen here. But this is very typical of a nice healthy cell. There you see some mitochondria